Well, welcome everybody. I want to welcome the audience. This is Astrid Pavlovsky. I'm a hematologist in Buenos Aires, Argentina. And I would like to share with you some of the latest results and very interesting results on CLL from the virtual EHA. And we will just go on to see first-line treatment for CLL. Okay, so we will start talking about what's going on with first-line treatment in CLL. There are lots of new options today for first-line treatment with these novel agents. And we saw the final results or the longer follow-up of CLL14 from the German Hodgkin's study group. This CLL14 is for treatment for previously untreated patients with CLL and coexisting medical conditions. And patients were randomized to receiving either venetoclax or obinutuzumab or chlorambucil or obinutuzumab. And one of the big benefits in this treatment is that it's only 12 months treatment compared to other which are chronic treatments. And what we saw with almost 4 years follow-up is that there's still a very big benefit on the arm of venetoclax or obinutuzumab with a PFS that was not reached and a 3-year PFS of 82%. So we see that most of the patients maintain their good response and are free of progressive disease compared to chlorambucil or obinutuzumab, which one might argue that the comparable arm is too weak, but still we see the very important benefits on the venetoclax or obinutuzumab arm. And something different and important from the previous presentation is that now we can also see a PFS on patients with mutated IGHV. Before, we saw that there was no difference, and we see that at 24 or 18 months, there was no difference for PFS between mutated venetoclax or obinutuzumab and mutated chlorambucil or obinutuzumab, and now the PFS benefit is seen in all arms. Something that we might have to take into account, and this is a new information we have, that in the venetoclax or obinutuzumab, there was a higher percentage of secondary primary malignancies, especially when we look at the solid tumors. There were 10 events in venetoclax or obinutuzumab arm versus 3 in chlorambucil or obinutuzumab, and this was not seen in hematological malignancies. So maybe further follow-up is necessary to see if how relevant this is in this treatment arm. And going on with first-line treatment, this is a combination, this is the CAPTIVATE MRD cohort, and this is a treatment where both ibrutinib and venetoclax are used in combination with untreated CLL. So we have a first lead-in 3 cycles of ibrutinib with 420 milligrams, and after these 3 cycles, venetoclax is added in. So we will see these first results, and in the future, they will show us the results of the MRD-guided maintenance period. And what we see is, first of all, this is very important. We know that there's a concern about tumor lysis syndrome when you're using venetoclax in first line or as a first treatment. And having a ibrutinib lead-in period, most of these patients will lower the risk of tumor lysis syndrome, since most of them with ibrutinib will lower down the white blood cell count. So after ibrutinib lead-in, only 2% of the patients needed hospitalization to receive venetoclax. And we see that with this combination treatment, there was a 97% overall response rate with 46%, 51% CR rate, and most of these patients, 70%, obtained MRD undetectable disease in bone marrow. So this is also a very attractive treatment. And finally, this combination treatment for this small but very high-risk group of CLL patients, and those are patients with a TP53 mutation or 70p deletion at diagnosis. So these are the preliminary safety and efficacy results of the triple combination of obinutuzumab, ibrutinib, and venetoclax for this group of high-risk patients. And also we see that there's an induction period with obinutuzumab and ibrutinib, and only on day 22 of cycle 1, venetoclax was added. 6 cycles of this triple combination, then consolidation with venetoclax and ibrutinib, and then maintenance with ibrutinib. So this is a very, what seems to be very active disease for this high-risk group of patients. We see that considering that all of them had either 17p mutation or 17p53 mutation or 17p deletion, or both of them, 78% were unmutated IGVH. And we see that with this combination, almost 60% of the patients achieved a CR, and most of them, between 95% obtained undetectable MRD in peripheral blood and 87% in bone marrow. So we need, this is response after 15 cycles. So this is also very attractive for this group of patients where we know that chemotherapy or chemoimmunotherapy is not an option. So we are learning a lot about CLL and first-line treatment with all these different options and these different combinations. So the big challenge is to know which is the best of all these to offer our patients. And I think this is where we have to first know our patient, know his age, his comorbidities, his preference, the aim of the treatment, and also to know about all of the very many prognostic factors that we are learning about. And with this information, try to choose the best treatment regarding a good balance between efficacy, economy, quality of life, the length of the treatment, and also the availability within each region or each country that we have to choose within these different options. Thank you very much, and I hope we continue learning about this very interesting disease.